Hi class, today we're going to go over how to interpret ABGs. It's not as hard as you might think. Alright, so when we're looking at acid-base imbalance, when we're taking care of patients at the bedside, what we're going to start off with is looking at the pH. Right? Your pH has to be within a certain level. It can't be too acidic or too alkalotic, because then your patient's body, the cells, the organs, the systems cannot function properly. So all of your cells and your body, your organs, all function best when the pH level is between 7.35 and 7.45. So we're talking about an acid-base balance, okay? It's got to be balanced on the pH in order for your cells, your organs to work well. So when we have imbalances, that's where nursing and physicians come in to try to correct those imbalances and save the patient. So with your pH, when you have a low pH, this is going to lead to an acidotic, sorry, my stylus is not acting correctly. This is going to lead to an acidotic state. If you have an elevated pH, then this is going to lead to an alkalotic state. Now, what we talk about when we're interpreting ABGs is two different values. We're talking about the first value, which is your carbonic acid, also called your CO2 levels or your carbon dioxide. And you know that that is cellular waste. So as the cells metabolize and give off waste, it's carried through the bloodstream up to the lungs, and it is breathed off in the form of CO2. So when you're looking at, say, respiratory acidosis, for an example, you're looking at an elevated CO2 level, which means that there's too much CO2 in the blood. All right, so too much CO2 in the blood is going to lead to an acidotic state, and too little CO2, if your CO2 is low, then that's going to lead to an alkalotic state. And our second value that affects the pH levels in patients is your bicarb. Now, your bicarb is secreted by the kidneys. So this right here is the difference when we're looking at ABGs. Your CO2 level is respiratory. We're talking about the respiratory system. And when we're referring to the bicarb or the HCO3, we're talking about the body system, the kidneys. So that is metabolic. So that's going to be your differences between respiratory acidosis, alkalosis versus metabolic acidosis, alkalosis. So now bicarb is secreted by the kidneys, and the normal level is 22 to 26. Now this is a base, it's a buffer for the acid in the blood. So when you have too much bicarb, it can lead to an alkalotic state, and if you have too little, it can lead to an acidotic state. All right, so too much bicarb is alkalotic, too much CO2 is acidotic. You don't really need to worry too much about the PO2 levels at this time. You don't necessarily need to have that number in order to interpret an ABG. That has a little bit different meaning for the patient at the bedside. So we'll talk about that a little bit later. All right, so when we're looking at, hold on here. When we're looking at interpreting ABGs, we're going to be looking at 4 different problems that the patient might have. All right, respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis. So those are the 4 things that we're going to be looking for. All right, so number one on the list is respiratory acidosis. It's one of the more common acid-base imbalances that you're going to see in your patient population, particularly if you're working in the ICU with patients that are ventilated, or if you're working in the ER with patients that come in and are either in respiratory distress, or maybe they're having a lot of pain from an accident and we've given them a little too much sedation, a little too much morphine. You'll see this in your patient population that is struggling with opiate addiction, heroin overdose, oxy overdose, Vicodin, too much opioids. And the main issue when it comes to respiratory acidosis is hypoventilation. So this is due to a low respiratory rate. So what is respiratory acidosis? Okay, carbonic acid. It's an excess of carbonic acid, otherwise called carbon dioxide. And you can also think of it as your hydrogen ions. It's an acid. Hydrogen is an acid. All right, so when we have too much carbonic acid, that means that your lungs are not breathing off enough CO2. So it is a low respiratory rate problem. It's a failure to remove the carbon dioxide from the blood. It's building up. You're getting more and more and more. Now, the body is really good at compensating when it's having problems. And when it comes to respiratory acidosis, the body can compensate. The kidneys can increase the bicarb. But the problem is this takes about 24 hours before you get enough bicarb to have any effect on that CO2, to be a buffer for that CO2. So the patient's not going to do well in the meantime. That's when nursing comes in. RTs come in, doctors, ventilators. We have to support the patient in the meantime and try to treat this respiratory acidosis. So what is the main problem? Well, if the patient is in respiratory distress, they might need to be ventilated. All right, so take a patient scenario like this. The patient has a heroin addiction and they've taken too much heroin and the ambulance brings them in and they're in respiratory distress. The respiratory rate is only 3. So because they're not breathing off that CO2, they're not breathing off the CO2, it has collected in the blood and put the patient into respiratory acidosis. So while in the ER, the patient gets ventilated, they get put on mechanical ventilation, and at that time, the RT chooses a respiratory rate on the ventilator of, say, something high, like 18, because we want to breathe off a lot of CO2. We want to get that CO2 out of the blood. The patient has to breathe more in order to do that. So we set the initial rate at 18, which is a high respiratory rate. The patient breathes off. Now, say like in an hour, the RT will usually come back either after intubating someone or making any changes on a ventilator setting. The RT can come back and recheck. All right, so now the patient's been at a high respiratory rate for an hour. The RT comes back and does a repeat ABG, and then at that time, we have overshot our goal. All right, so here was our goal. The patient was in respiratory acidosis over here. We put them on the ventilator, and our goal was to normalize them here, but it went a little bit too far, and it breathed off too much carbon dioxide. Now we've put the patient into respiratory alkalosis, because respiratory alkalosis is the exact opposite. All right, it's the exact opposite of respiratory acidosis. It is not enough of carbonic acid, which remember we said was CO2. All right, so it's not enough. This occurs with hyperventilation, so this is an increased respiratory rate. So for the patient that we're referring to, they came in respiratory acidosis, they were ventilated, and we kind of did too good of a job. We overshot our goal. The patient had an elevated respiratory rate for too long, and now they've got the opposite problem. So what can we do for this patient that is mechanically ventilated? Well, that's the nice thing about a patient being mechanically ventilated is we get to control the respiratory rate. Okay, so now we're going to lower that respiratory rate down to, for the mechanically ventilated patient, they came in with a respiratory rate of 3. We bumped it up to 18 by mechanically ventilating them. Well, now we can maybe lower it down to, around 10. All right, and see how that goes. Now we've made changes on the ventilator. We'll come back in an hour and recheck that ABG, and hopefully we have normalized that pH and gotten the pH down to a normal level. So that's like a patient scenario situation, and that's very common. As an ICU nurse, I see that quite often when somebody is not doing well at the bedside, they get ventilated, and we kind of overshoot our goal a little bit. Or what can happen is the patient just really starts getting better and doesn't need that mechanical ventilation, and then we need to extubate them. All right, so we talked about mechanical overventilation being a very common cause of respiratory alkalosis. That's an easy fix. You just fix the underlying cause by lowering down those respirations. This can happen sometimes as well. Respiratory alkalosis can happen as well with anxiety. You've probably heard about, patients that are hyperventilating, and we want them to breathe into a paper bag, right? So what's happening is they're breathing out into a paper bag, which is CO2, and if they're breathing that back in, then that way they're breathing back in their own CO2, and that's going to help to normalize that pH, give them back some of that CO2 that they need because they currently have a deficit. You might occasionally see respiratory alkalosis in a patient that has had some sort of brain trauma. Maybe they've had some sort of accident or stroke or trauma to a portion of the brain that controls your vital signs and controls your respirations. And because of the damage to that brain, that portion of the brain, it's not working well enough. It will cause the patient to breathe too much. They've lost their ability to regulate. And you will see this sometimes in that patient population, head trauma. But most often, as a bedside nurse, what you're going to see it in is mechanical overventilation. All right, so let's go ahead and move on to metabolic acidosis. I'm at 13 minutes now, so I'm just going to let you know I'm going to stop this video at 15 and pick up on a second video because otherwise I have uploading problems to YouTube. And sometimes students have problems downloading videos that are longer than about 15 minutes. So this is probably going to be in about 3 different videos, just to let you know. All right, so metabolic acidosis. So let's go down to our little sheet here. Okay, so we talked about, we talked about respiratory acidosis and respiratory alkalosis. Now we're going to talk about metabolic acidosis. So we're already halfway through. All right, so metabolic acidosis. This is acidosis, just like we talked about before, only it's an acid other than carbonic acid. So we're not talking about bicarb anymore. It's acidosis, but it's related to something else. So the 2 things that you're going to see is it could be ketoacidosis, which is caused by patients in DKA, or it could be lactic acidosis, which is caused by your patients that are in shock or sepsis. All right, it can also be caused by severe diarrhea, and that's because during diarrhea, there is a greater loss of bicarb through the stool, the watery stool, versus any acid. So it ends up being an imbalance that way. All right, and then the kidneys will lose the ability in chronic kidney disease. They're going to lose the ability to reabsorb bicarb and secrete hydrogen ions, which is an acid. So you end up with an imbalance that way as well. But it's easy to remember if you think of it this way. It's an acid other than carbonic acid, so an acid other than CO2. So it's being caused by something that's going on with the body, not the respiratory system. Now, the one thing that'll happen is your body tries to compensate, and you'll get this deep, rapid breathing called Kussmaul respirations. And what that is it's very rapid, deep respirations because the body is trying to blow off CO2, which is an acid, simply just to help the patient, just to help reduce the amount of overall acid in the blood. Unfortunately, it's a compensatory mechanism that doesn't necessarily work. It's just the body's ability to, throw a glass of water on a raging fire. So we're going to try to breathe off CO2, but CO2, remember, is not the problem. It's an acid other than carbonic acid, so it's not really going to be helpful. All right, so we're going to stop the video here and then pick up with metabolic alkalosis.